What happens during labor and birth? First stage of labor. During the first stage of labor, contractions make your cervix gradually open up, dilate. This is usually the longest stage of labor. At the start of labor, the cervix starts to soften so it can open. This is called the latent phase, and you may feel irregular contractions. It can take many hours, or even days, before you're in established labor. Established labor is when your cervix has dilated to more than 3 cm and regular contractions are opening the cervix. During the latent phase, it's a good idea to have something to eat and drink as you'll need the energy once labor is established. If your labor starts at night, try to stay comfortable and relaxed. Sleep if you can. If your labor starts during the day, keep upright and gently active. This helps your baby move down into the pelvis and the cervix to dilate. Breathing exercises, massage and having a warm bath or shower may help ease pain during this early stage of labor. When to contact your midwives. Contact your midwifery team if your contractions are regular and coming about 3 in every 10 minutes. Your waters break. Your contractions are very strong and you feel you need pain relief. You're worried about anything. If you go into hospital or your midwifery unit before your labor has become established, they may suggest you go home again for a while. Once labor is established, your midwife will check on you from time to time to see how you're progressing and offer you support, including pain relief if you need it. You can either walk around or get into a position that feels comfortable to labor in. Your midwife will offer you regular vaginal examinations to see how your labor is progressing. You don't have to have these if you don't want to. Your midwife can discuss with you why she's offering them. Your cervix needs to open about 10 cm for your baby to pass through. This is what's called being fully dilated. In a first labor, the time from the start of established labor to being fully dilated is usually 6 to 12 hours. It's often quicker in second or third pregnancies. When you reach the end of the first stage of labor, you may feel an urge to push. Monitoring your baby in labor. Your midwife will monitor you and your baby throughout labor to make sure you're both coping well. This will include using a small handheld device to listen to your baby's heart every 15 minutes. You'll be free to move around as much as you want. Your midwife may suggest electronic monitoring if there are any concerns about you or your baby, or you choose to have an epidural. Electronic monitoring involves strapping 2 plastic pads to your bump, and possibly a clip attached to the baby's head, a fetal scalp monitor. These are attached to a monitor that shows your baby's heartbeat and your contractions. You can ask to be monitored electronically even if there are no concerns. Having electronic monitoring can sometimes restrict how much you can move around. If you have electronic monitoring with pads on your bump because there are concerns about your baby's heartbeat, you can take the monitor off if your baby's heartbeat turns out to be fine. A fetal scalp monitor will usually only be removed just as your baby is born, not before. Speeding up labor. Labor can sometimes be slower than expected. This can happen if your contractions aren't coming often enough or aren't strong enough, or if your baby is in an awkward position. If this is the case, your doctor or midwife may talk to you about 2 ways to speed labor up: breaking your waters or an oxytocin drip. Breaking your waters. Breaking the membrane that contains the fluid around your baby, your waters, is often enough to make contractions stronger and more regular. This is also known as artificial rupture of the membranes, ARM. Your midwife or doctor can do this by making a small break in the membrane during a vaginal examination. This may make your contractions feel stronger and more painful, so your midwife will discuss pain relief with you. Oxytocin drip. If breaking your waters doesn't work, your doctor or midwife may suggest using a drug called oxytocin, also known as syntocinon, to make your contractions stronger. This is given through a drip that goes into a vein, usually in your wrist or arm. Oxytocin can make contractions become stronger and more regular quite quickly, so your midwife will discuss pain relief options with you. You will also need electronic monitoring to check your baby is coping with the contractions, as well as regular vaginal examinations to check the drip is working. Second stage of labor. The second stage of labor lasts from when your cervix is fully dilated until the birth of your baby. Finding a position to give birth in. Your midwife will help you find a comfortable position to give birth in. You may want to sit, lie on your side, stand, kneel, or squat, although squatting may be difficult if you're not used to it. If you've had lots of backache while in labor, kneeling on all fours may help. It's a good idea to try out some of these positions before you go into labor. Talk to your birth partner so they know how they can help you. Find out what your birth partner can do. Pushing your baby out. When your cervix is fully dilated, your baby will move further down the birth canal towards the entrance to your vagina. You may get an urge to push that feels a bit like you need to have a poo. You can push during contractions whenever you feel the urge. You may not feel the urge to push straight away. If you have an epidural, you may not get an urge to push at all. If you're having your first baby, this pushing stage should last no longer than 3 hours. If you've had a baby before, it should take no more than 2 hours. This stage of labor is hard work, but your midwife will help and encourage you. Your birth partner can also support you. What happens when your baby is born? When your baby's head is almost ready to come out, your midwife will ask you to stop pushing and do some short breaths, blowing out through your mouth. This is so the head can be born slowly and gently, giving the skin and muscles of the area between your vagina and anus, the perineum, time to stretch. Sometimes your midwife or doctor will suggest an episiotomy to avoid a tear or to speed up delivery. This is a small cut made to the perineum. You'll be given a local anesthetic injection to numb the area first. Once your baby is born, the cut or any large tears will be stitched up. Find out about your body after the birth, including how to deal with stitches. Once your baby's head is born, most of the hard work is over. The rest of the body is usually born during the next 1 or 2 contractions. You'll usually be able to hold your baby straight away and enjoy some skin-to-skin time together. You can breastfeed your baby as soon after birth as you like. Ideally, your baby will have their first feed within 1 hour of the birth. Read more about breastfeeding in the first few days. Third stage of labor. The third stage of labor happens after your baby is born, when your womb contracts and the placenta comes out through your vagina. There are 2 ways to manage this stage of labor. Active, when you have treatment to speed things up. Physiological, when you have no treatment and this stage happens naturally. Your midwife will explain both to you while you're still pregnant or during early labor, so you can decide which you would prefer. There are some situations where physiological management isn't advisable. Your midwife or doctor can explain if this is the case for you. What is active management? Your midwife gives you an injection of oxytocin in your thigh as you give birth or shortly after. This makes your womb contract. Evidence suggests it's better not to cut the umbilical cord straight away, so your midwife will wait to do this between 1 and 5 minutes after birth. This may be done sooner if there are concerns about you or your baby, for example, if the cord is wound tightly around your baby's neck. Once the placenta has come away from the womb, the midwife pulls the cord, which is attached to the placenta, and pulls the placenta out through your vagina. This usually happens within 30 minutes of your baby being born. Active management speeds up the delivery of the placenta and lowers your risk of having heavy bleeding after the birth, postpartum hemorrhage, but increases the chance of you feeling nauseous and vomiting. It can also make after pains, contraction-like pains after birth, worse. What is physiological management? No oxytocin injection is given, and the third stage of labor happens naturally. The cord isn't cut until it's stopped pulsing. This means blood is still passing from the placenta to your baby. This usually takes around 2 to 4 minutes. Once the placenta has come away from the womb, you should feel some pressure in your bottom and contractions, and you'll need to push the placenta out. It can take up to an hour for the placenta to come away, but it normally only takes a few minutes to push it out. If the placenta doesn't come away naturally or you begin to bleed heavily, you'll be advised by your midwife or doctor to switch to active management. You can do this at any time during the third stage of labor. A cesarean section, or C-section. A cesarean section, or C-section, is an operation to deliver your baby through a cut made in your tummy and womb. The cut is usually made across your tummy, just below your bikini line. A cesarean is a major operation that carries a number of risks, so it's usually only done if it's the safest option for you and your baby. Around 1 in 4 pregnant women in the UK has a cesarean birth. Why cesareans are carried out. A cesarean may be recommended as a planned, elective procedure or done in an emergency if it's thought a vaginal birth is too risky. Planned cesareans are usually done from the 39th week of pregnancy. A cesarean may be carried out because your baby is in the breech position, feet first, and your doctor or midwife has been unable to turn him by applying gentle pressure to your tummy, or you'd prefer they did not try this. You have a low-lying placenta, placenta previa. You have pregnancy-related high blood pressure, preeclampsia. You have certain infections, such as a first genital herpes infection occurring late in pregnancy or untreated HIV. Your baby is not getting enough oxygen and nutrients. Sometimes this may mean the baby needs to be delivered immediately. Your labor is not progressing or there's excessive vaginal bleeding. If there's time to plan the procedure, your midwife or doctor will discuss the benefits and risks of a cesarean compared with a vaginal birth. Asking for a cesarean. Some women choose to have a cesarean for non-medical reasons. If you ask your midwife or doctor for a cesarean when there are not medical reasons, they'll explain the overall benefits and risks of a cesarean to you and your baby compared with a vaginal birth. If you're anxious about giving birth, you should be offered the chance to discuss your anxiety with a healthcare professional who can offer support during your pregnancy and labor. If after discussing all the risks and hearing about all the support on offer you still feel that a vaginal birth is not an acceptable option, you should be offered a planned cesarean. If your doctor is unwilling to perform the operation, they should refer you to a doctor who will. What happens during a cesarean? Most cesareans are carried out under spinal or epidural anesthetic. This means you'll be awake, but the lower part of your body is numbed so you will not feel any pain. During the procedure, a screen is placed across your body so you cannot see what's being done. The doctors and nurses will let you know what's happening. A cut about 10 to 20 cm long will usually be made across your lower tummy and womb so your baby can be delivered. You may feel some tugging and pulling during the procedure. You and your birth partner will be able to see and hold your baby as soon as they have been delivered if they're well. A baby born by emergency cesarean because of fetal distress may be taken straight to a pediatrician for resuscitation. The whole operation normally takes about 40 to 50 minutes. Occasionally, a general anesthetic, where you're asleep, may be used, particularly if the baby needs to be delivered more quickly. Recovering from a cesarean. Recovering from a cesarean usually takes longer than recovering from a vaginal delivery. The average stay in hospital after a cesarean is around 3 or 4 days, compared with an average of 1 or 2 days for a vaginal birth. You may experience some discomfort in your tummy for the first few days. You'll be offered painkillers to help with this. When you go home, you'll need to take things easy at first. You may need to avoid some activities, such as driving, until you have had your postnatal checkup with the doctor at 6 weeks. The wound in your tummy will eventually form a scar. This may be obvious at first, but it should fade with time and will often be hidden in your pubic hair. Risks of a cesarean. A cesarean is generally a very safe procedure, but like any type of surgery, it carries a certain amount of risk. It's important to be aware of the possible complications, particularly if you're considering having a cesarean for non-medical reasons. Possible complications include infection of the wound or womb lining, blood clots, excessive bleeding, damage to nearby areas, such as the bladder or the tubes that connect the kidneys and bladder, temporary breathing difficulties in your baby, accidentally cutting your baby when your womb is opened, future pregnancies after a cesarean. If you have a baby by cesarean, it does not necessarily mean that any babies you have in the future will also have to be delivered this way. Most women who have had a cesarean section can safely have a vaginal delivery for their next baby, known as vaginal birth after cesarean, VBAC. But you may need some extra monitoring during labor just to make sure everything is progressing well. Some women may be advised to have another cesarean if they have another baby. This depends on whether a cesarean is still the safest option for them and their baby.